Good evening, and many thanks for watching KTN. Welcome to this edition of Health and Wellness. My name is Dennis Aseto, and on today's show, we want to talk about gastrointestinal disease. Yes, long word. What does it mean? A lot of science today, but we're going to make it easy for you to understand on the show today. We have Dr. Aditya Naragund. Yes, Dr. Aditya Naragund, who is a senior consultant GI and HPB surgeon. Dr. Welcome on board.
Asante.
Yeah. We talk about gastrointestinal disease. Then there is GI and HPB. Let's just break it down simply. Okay. What does that mean?
When we say gastrointestinal disease, it is any problem concerning our gastrointestinal system, which starts from the mouth, the food pipe, the stomach, the intestines, the large intestine, the liver, the pancreas, the biliary system. So all this constitutes the GI system. And any diseases of this region are called gastrointestinal diseases. And when you come to my qualification, GI and HPB surgery, it means I deal with surgeries of the liver. HPB is hepato-pancreato-biliary, liver, pancreas, and bile duct surgeries, and surgeries of the gastrointestinal tract, esophagus, stomach, colon, rectum, all these surgeries, they come under the purview of GI and HPB surgery.
Yeah. So let's talk about the entire ecosystem. I'll call them ecosystem that you're talking about, because it starts from the mouth going all down to the intestines, right?
Yes.
So what are some of the common diseases or conditions that you find in your specialty?
Right. When we look at, I mainly deal with cancers of the GI and hepatobiliary system. But if we look at it in general, the commonest problems we see are related to the stomach, gastritis issues, reflux issues, issues of bloating, issues of colon, rectum, constipation. These are all the common issues which we see. But when we look at cancers in particular, colon, rectum, pancreas, liver, and the esophagus and stomach, these form a lot of the diseases we treat regularly.
So I want to look at a situation where we find ourselves in positions where all these diseases are there. And remember, a disease is caused by something, right? So by the time I'm coming to you for, say, surgery, by the time I'm coming for you that my pancreas has a problem, what would be some of the reasons, what could be the causes that would then force me to come to you to seek for assistance? Because then again, by the time you're coming there, I'm assuming one question you'd ask is, how have you been eating? How has been your digestive system? Have you been experiencing any difficulties doing all that? So what would be the symptoms and what would be the causes before I get to you?
Right. So the commonest symptom we see is persistent abdominal pain, which doesn't go away. That is one. Gastritis-like symptoms. I call it gastritis-like because it need not be gastritis. It gives symptoms like that. Abnormalities in passing stool, blood in stools. This is one more common symptom. Any change in the normal pattern, right? We all have fixed patterns. If there is a sudden change or a change which seems to persist, which is not normal, we have that feeling that this is not normal, that is a time when we should seek help. Now, the common thing we see in our practice is that somebody has gastritis-like symptoms, they go to the pharmacy, they're given tablets, they take the tablets, they feel better, they ignore. So it happens not for days or weeks, it happens for months and months. So any symptom which is not going away, which is recurrent, should always be evaluated by an expert of that system. This is something which we have to strongly look at. And if we look at certain habits, somebody who has a lot of addiction to smoking, alcohol, irregular food habits, unhealthy diet, lack of exercise, so such any family history of cancers, such patients or such people should have additional screening protocols, get themselves checked more frequently, and always seek help before the problem blows out.
Yeah. You mentioned gastritis-like symptoms.
Yes.
I just want to know what these symptoms are.
Correct. So that's one of the most common symptoms. So all of us, we would have suffered from gastritis at some point. In Kenya, H. pylori is extremely prevalent. And I saw that everybody has been treated for H. pylori, not once, not twice, 4 times, 5 times, right? So when we have symptoms like bloating, burning sensation in the stomach, burning sensation in the chest, so these are gastritis symptoms. But sometimes if we have issues of the pancreas, it causes similar pain in the stomach. Slightly different, but for a patient it is still gastritis because it hurts in the upper part of the tummy. That is a gastritis-like symptom. Difficulty in swallowing, when they try to swallow food, it seems like it's getting stuck. We have to push it down. That is something like a reflux-like symptom, but it's not reflux. If you look at it closely, it's not reflux. It's something different, right? Food should not get stuck. But we assume that it is because of reflux. We assume it is because of gastritis. Gallbladder stones, simple gallstones can cause dyspeptic symptoms, where we feel a lot of burping, we feel full after food. These are certain symptoms which we tend to ignore. Any tummy pain which goes to the back would suggest a pancreatic pain. But for a common man, again, they think, oh, it's upper abdominal pain, it's gastritis. We'll pop a Panadol, we'll take esomeprazole and we'll be okay. And it does help for a bit, but that is not the way we should look at it. So we should always, if it is persisting, we should seek help.
You've just mentioned the symptoms, right? And I'm seated here and I'm like, have I ignored it once before? But it is a common occurrence where you find that based off how an individual understands their body, they would tend to assume that to be a gastritic-like symptom and treat it using the regular aspirin, or you take any
esomeprazole, omeprazole,
things that you just get off the counter and you're good to go.
Yes.
But there is need then, therefore, for health-seeking behaviors to change.
Exactly.
Because the reason why you'd find someone assuming that to be normal symptom is because the health-seeking behavior tells them you can walk to a pharmacy, to a chemist, pop a pill, and you're good to go. So let's speak in terms of health-seeking behavior and how that exposes one to further complications down the line.
Correct. So this is very common even back home in India, where the pharmacists are sort of a replacement for a physician. So we go to the counter and we say, I have this symptom, and they just give a drug. I have seen that even antibiotics are given without prescriptions, which is very worrying in the long run. So the first thing is, it's okay to pop an omeprazole once in a while. It's okay to pop one paracetamol. But when that becomes regular, we should always think, why is it happening? Especially if it was not there before and there is a change. Along with that, there are certain other symptoms which could, like, you could start losing weight. You could start having loss of appetite. So when we have certain other symptoms, it should immediately trigger that something is not right. I shouldn't be popping this pill so frequently. And it is always advisable, especially antibiotics, never pop them without a prescription, without seeing your physician. And any symptom which is not going away, always seek a physician's opinion so that they can refer you to the right person, investigate why this is happening, and not just give you medicines. Investigations and screening form a very vital part of detecting diseases early. So that is something which we should always remember. Once or twice is okay. Recurrent, seek help.
Yeah. From your practice, are we seeing these cases increasing?
Oh, yes, definitely. There are a lot of reasons why this is happening. One of the main thing is lifestyle. So the way our forefathers used to work in the fields, a lot of exercise, that is missing. A westernized diet, a lot of fast food, burgers, sodas. The diet has changed from the traditional healthy food to more of fast food based diet. The habits, access to alcohol, smoking is on the rise. And the quality of the vegetables, the use of pesticides to get better looking vegetables is a problem because in the long run they cause a lot of trouble.
I look at it from a point where if you speak to those who are a little bit advanced in terms of age, the elderly, right? They will tell you we are able to get to this age because of what we eat. Most of us eat from our backyard. We grow our own food.
Yes.
We know what we're putting into that food that we are consuming. But you look at the modern world, because of population, everyone wants quick fix as we move, quick fix as we move. So then how do we have this conversation? Because I don't know, from where I sit, we should look at disease burden in our jurisdictions in terms of preventative other than curative. Because by the time I'm coming to you, it's because I'm pretty much on a bed I can't move. I need to be opened up to deal with that. Are we looking at conversations around preventative medicine as opposed to curative?
Yeah, so that is the ultimate goal of healthcare. And that should be the goal of every government all over the world, to form preventive medicine as the basis of the healthcare system. Unfortunately, we are at the treatment part of it. Most hospitals are treating diseases. The preventive part comes at the social level, at the economic level, at the policy formation level, where there is regulation of what is used, how the foods are cultivated, regulation of the water quality, having policies where youth are encouraged to exercise, having policies where there is stringent anti-addiction measures. These are things which go a long way in the preventive factor. And reaching the grassroots, the villages, to get themselves tested at an early stage, not to ignore symptoms. Unfortunately, in the villages here in India, it's the same. We have a lot of patients who ignore, they come at very advanced stages because they don't know, there's lack of knowledge. So disseminating the healthcare knowledge at the primary levels is extremely important. What is important, what is good, what is not. Our traditional, as you said, our forefathers, our grandfathers' generation, they had fantastic physical activity, fantastic food, quality of food, and that goes a very long way. We see they live up to 85, 90, 95, very healthy. And we have now 40 years, 3 stents in the heart, 4 surgeries, cancers. That is an unfortunate outcome of what we can say modernization. Yeah, it is essential modernization, but it has its own drawbacks. We need to get, the healthcare needs to be given more prominence by the governments.
Yeah, and you see as well, Daktari, we want to look at medicine in terms of, they usually say, your health is what you eat, right?
Of course.
And you look at gastrointestinal diseases, then it actually speaks to our mouth and everything else that comes thereafter. But then again, there is another component that everyone keeps on pumping that a lot, which is, as much as you're eating healthy, if you're not moving around, if you're not exercising, then you're just doing, it's a zero-sum game. You're not ended anywhere. So let's just speak in terms of, we need to be cognizant of what it is we do, what it is we eat, but we equally need to be aware of our bodies and move around and exercise. Many ask just how critical then is exercising in our overall daily life and also our health?
Exercising is it's as vital as what we eat. You know, we tend to ignore that a lot. In fact, there have been recent studies where after cancer, somebody has recovered from cancer, and you look at two groups of people, the ones who exercise and ones who don't, the incidence of recurrence of cancer is as low as 7 to 15% affected by just people who exercise. And that, when multiplied to the population, is a huge number. Now, we may be eating a lot of healthy food, but if your body is not using it, it is as good as having the extra calories stored in, which is not good. We tend to become obese. You may be eating only healthy food, but you're not using it. And exercise improves the metabolism. It makes us more active. It releases a lot of endorphins. Not only physical health, mental health becomes very well in patients or in people who exercise. It induces a lot of positivity. And our liver health, pancreas, gut, everything, brain, the lungs, it affects all the organs in a positive way. So I think physical education, exercises should be a part of everybody's routine. And we can prevent obesity, diabetes, so many metabolic illnesses by just exercising.
Yeah. So you have been in Nairobi for a medical camp, right?
Yeah.
And with the medical camp that has been taking place in Nairobi, one would then ask, what is it that you found that is unique to Kenya that perhaps then would inform the kind of medication or interventions that need to be put in place?
Well, one thing I noticed is, I already told you, a lot of H. pylori. And the other is, what I found is that patients are a little scared to come to the doctors. They are scared of what will the diagnosis be. They are scared to get themselves tested. I have seen patients who have been diagnosed with a problem 7 months back, which could potentially be a cancer, and they have not sought help. And there have patients who, I met a patient who said, I had a family member who had cancer, and this could be a cancer, so I don't want to be tested. I don't want cancer. That is a denial mode, you know. I mean, if you have a problem, you get it solved. You don't say, oh, I don't have the problem. You can't say that. That is something which I saw very frequently. If it comes to diet, we see a lot of tea, very hot stuff being consumed a lot of milk. And in India, we have a small cup. Here it's a big mug.
We love our teas.
Yeah. So
most of them call it mzinga.
Yes, yeah. So that hot, that heat is, I was going through literature, and that is one of the causes that there are a lot of esophageal issues in Kenya. It's considered as a esophageal cancer corridor. And one of the reasons is considered to be hot beverages, very hot porridge or very hot tea consumed in large quantities, which gives that injury to the lining of the food pipe and the stomach. So this is also one other thing. H. pylori, very common. Again, water needs to be better treated. It's a waterborne bacteria, very common here, associated with stomach cancer, associated with lymphomas. And that is also very common in Kenya, much more common than back home. Though we have a high incidence, I see that here patients are treated many times, not once, not twice, many times. So these are some things which are unique, which I have seen in my camp in the last few days.
Yeah, because, you know, you've talked about H. pylori, and yes, especially our age, you find almost everyone, I'm lucky enough not to have treated a H. pylori. But you find that it's a common occurrence. Like every other time someone is popping a pill because of H. pylori, once, twice, 3 times, they're treating it. Should that be a cause of concern for anyone, that they perhaps need further investigation as to why they keep on treating H. pylori?
So one more thing which we see here is H. pylori is treated before an endoscopy.
Okay.
Right? So we do stool test or a urease breath test. We see there is H. pylori We put them on a kit. Now, back home, our policy is we generally, because H. pylori is very common, we should not be treating everybody, right? What our policy is to do an endoscopy first, look at how much injury it is causing, how much symptoms it is causing, and then we treat it. Because what happens is H. pylori keeps coming back. That is not because of what you're doing, but it's because of the water and the way the cleanliness of the water around, how well it is treated. You can't prevent that. It's not in our hands. But that doesn't mean you keep taking antibiotics for 14 days, once in 3 months, no, because that results in more damage to your intestine by the antibiotics as well, resulting in resistance, a lot of gut issues, then you are bloated, your stool system changes because of the antibiotics. It has a lot of issues. So I would not treat H. pylori recurrently with antibiotics. That is something which we have to, you treat it once, but if it is happening again, try and do an endoscopy, find out how important it is. It need not be a H. pylori infection which is causing him the trouble. It could be something else.
Yeah, because we talk about H. pylori and what it is. It is a water problem. That squarely then speaks to if individuals are coming from a specific locale with the same disease, perhaps then that is a communication that needs to come from the patient themselves. We talk about the doctor and the need to address that and link in with government, who is the provider of the service, that is water. That we cannot just deal with treating H. pylori without treating the cause of the
system.
Yeah.
Yes.
So it is. So conversations then should not just end at the hospital. Perhaps that it needs to be expanded to even government in terms of policy, right?
Correct. So when we look at the West, America, if a person is treated for H. pylori there, the chances of recurrence is 5%. In India, the chances of recurrence is 70 to 80%. So it all speaks about the hygiene levels in the way the water is handled. The government, the way the handlers, the people who cook, the way the utensils are used. So it's all a reflection of how clean the water is and how the handling of the water is happening. And that speaks volumes for how to go about controlling it, right? So the data is very, very clear on that the more cleaner it is, the more hygienic it is, the lesser the incidence of H. pylori.
H. pylori. We're talking about a gastrointestinal disease and what needs to be done. It is a question of how are our surroundings behaving? Is it clean? Are we handling our food right? And even in the event that you are unwell, having gastric issues, how do you go about it? How do you treat it? Are you treating it by popping a pill simply because you can walk to a chemist and get yourself a pop of the pill? Are you multi-treating the same thing but not seeking further diagnoses on the same? We're here to talk about that, what you need to do, what must be done, what the government must do, but all that after this short commercial break. Remember, this is Health and Wellness. And thank you for watching KTN. Welcome back. This is Health and Wellness. What are we talking about? Gastrointestinal disease. And here we have Dr. Aditya Naragund, who has been in the country for a wellness camp. Talks about what he has seen, that Kenyans, we are afraid of going to get tested to know exactly what it is we're dealing with. Perhaps we need to change that and go get the test we need so that we can be treated. But that notwithstanding, Daktari, when you talk about gastrointestinal disease, there is also the aspect of kidney problems, liver problems, everything that is interconnected, right? And when you talk about that specialty treatment, where would you rate where the world is in terms of treatment from your experience?
We are quite a long way now. I mean, when we look at medical treatment or surgical treatment, we are not looking at it very superficially. We go into the depth of the illness itself. We are moving away from generalized treatment to personalized healthcare, where we stop treating diseases as a general, and we look at it from a personal point of view. A same disease may have a different need for a different patient, especially when it comes to cancers. We are looking at genetics. When it comes to surgeries, we are looking at it with different ways we can get it done with the least amount of problems to the patient. And the healthcare has come a long way. There's a lot of things to still go ahead, but we have come a long way right now.
Yeah. So let's look at liver cancer and the treatment of the same. You know, it is a matter that is shocking that we see numbers continue going up.
Yeah.
What could be the reasons why we see liver disease, liver cancer on the rise?
Some of the commonest conditions is, number one is alcohol all over the world. Hepatitis B, hepatitis C, and in Kenya, I was going through literature, there is something called aflatoxins in maize which is stored in unhealthy conditions, and that is supposed to be one of the causes. Back home in India, where obesity is more prevalent, midriff obesity, we see something called as non-alcoholic steatohepatitis, where there is fatty liver. So we do a scan and we say there is fatty liver. And that fatty liver, in the long run, is known to be a cause for cirrhosis and also to an increased incidence of cancer or the general prevalent than the general public. In Kenya, particularly hepatitis B, hepatitis C, alcohol. These are the three things which need to be addressed. Storing of maize, of course, becomes again a storage policy, and that can be addressed easily. As a healthcare system, hepatitis B can be vaccinated against. Hepatitis C, if detected, can be cured, and alcohol is again a habit. So all these are very well preventable problems.
Doc, you know, in this country there's something called ugali. That is our staple. It's like roti. Ugali. So yes, roti to Indians, ugali to Kenyans.
Yes.
And it is from maize flour.
Correct.
That is our staple. And one of the problems that we've seen over time is even when you're taking the same to, say, the cereals board of the country, they would ask you to test it for aflatoxin level. And there are those who are sent back because the maize has not met the threshold.
Correct.
That would mean that the person who's been rejected because of aflatoxin with their maize would go back to the community and sell it locally. Yeah. So you find that perhaps when you talk about aflatoxin being one of the causes, one would then understand how that comes to play. Because if you go to government, if you go to government agencies, you would find that which has is at code, which has been checked. But locally, perhaps many Kenyans are consuming flour that has aflatoxin without them knowing. And with that being common knowledge, then speaks to government, speaks to code, speaks to awareness of Kenyans, perhaps.
Correct. So that is something which needs to be addressed and taken up by the policymakers. And I'm sure they would be able to have a better regulation. Kenyans should have the same standard as the rest of the world. Anybody should have the same standards. It is not, that is the basic right of every human. So I think that should be a policy, that such flour or such foods should not be accepted, neither here nor outside. I think many a times economics decides a lot of things, but we need to be caring for our own people too.
You know, by the time I'm coming, at what point should I be concerned about liver disease? You know, because most of the time you find that liver as is a complex matter. Many don't know when it is when they have a problem. So by the time they're coming to see you for diagnosis, it's pretty too late.
Yeah.
But when exactly, in terms of seeking help early, what should one be looking at?
Yeah, so there is a liver is very complex,
Yes.
you know. When I commonly compare it, if you look at it as a country, if a body is a country, the brain could be the president, the heart could be the prime minister, but who's running the country? It's the people, it's the workers, it's the factories, and the liver is the factory of the body. If the liver is not working, nothing will work. Whatever we eat, any food in the body goes through the liver removes the toxins, it takes away what is bad, filters it, sends it to the rest of the body. And liver health is unfortunately the least on the priority. It doesn't tell us, because it doesn't tell us that it is in trouble. It keeps working like the common people. We keep working till we are stretched to the core. And once it is in real trouble, that's when it starts showing up. So there is no early way of detecting a liver problem. If you want a liver, if you look at the liver function test, it tests the liver function. But by the time the liver function gets deranged, in a cirrhotic patient, it should go up to 70% of the liver should already be damaged. Otherwise, we are not going to detect that there is a liver problem just by a blood test, which is why we have certain criteria. Beyond a certain age, say 40, 50, depending on our habits, if we are alcoholic, we should get ourselves screened with a simple ultrasound scan, tell us how is the liver looking, do a liver function test, see if it is okay, everything is fine. If we have hepatitis B, hepatitis C, if we are alcoholic, then the screening should be even more stringent. We do once a year ultrasound, we do blood tests every year, we look at the liver function every year. And depending on patient to patient, we have to tailor the screening protocols so that we can detect diseases early. There are certain newer tests, not newer, we have fibroscans. Somebody has fatty liver. We look at it with a fibroscan, see how much fibrosis is there in the liver. Is it going towards cirrhosis? Take corrective actions. Do not ignore fatty liver. Many a times back home, somebody sees a fatty liver they say it's normal. There's just fatty liver, nothing's wrong. That is the number one mistake we are doing. A fatty liver is easily corrected with good diet, proper exercise. Follow it up 6 months later, look at it, see if it is normalized. If it's not normalized, then see why there is still persistent fatty liver. There could be something else going on. So that is how the treatment should be. That's how the screening should be for a liver problem.
Yes.
And you don't wait for symptoms in liver.
Because when you talk about liver problems, what I just hear you explain would be that it is very difficult to have, say, a standardized way of treating liver problems, because if it's a fatty liver, then you need to dig deeper to see what that is and how we treat it. Then there could be cirrhosis. By the time you're being diagnosed with cirrhosis, it's 70% of the liver is gone.
Yeah.
You know, you look at alcohol, there is no way you can tell someone is drinking. Someone could be drinking, say, 10 glasses, one is drinking one. But could be that the person who's taking a single glass, their liver cannot handle a single glass.
Exactly. Yes.
So then when you talk about liver disease and prevalence in India, in Kenya, or in the world, what are we looking at in terms of prevalence? How bad is it, or how good is it, or how manageable it is?
It is rising. The incidence is around 5 per. It's the 5th most common cancer, and it is rising in trend. 5 per 1 lakh population is what we look at. But it is, considering the whole population, it is one of the most prevalent problems. And the incidence of liver cancer also increases as the patient becomes cirrhotic. We see that 90% of the cancers are in cirrhotic patients only, liver cancers. And unfortunately, once a patient becomes cirrhotic, the treatment options are very less. You're looking at a liver transplant, if at all, and you know that a liver transplant comes with a lot of expense, a lot of long-term consequences to it. So the incidence is rising, but if you look at the reasons for the liver problem, most of them can be curtailed early. Hepatitis B vaccine is very simple, right? We can prevent hepatitis B. Hepatitis C, if diagnosed, can be treated, cured. So you are taking away what was traditionally the most common cause for a liver cancer or liver cirrhosis. Those have already been addressed. The others are quite well preventable.
Yeah. In your camp,
Yeah.
what was the story on liver cancer?
Well, I could see 2 patients who had liver problems. Liver cancer, I did not have in the last couple of days, but I have treated a lot of patients from Kenya back home in India with liver cancer. We have done liver surgeries, we have done transplants on the patients, and if they are fitting the criteria, of course. Otherwise, we put them on a lot of newer medicines, newer modalities of treatment to prolong survival. But it is the incidence of hepatitis B and hepatitis C here is higher than the rest of than the other areas, generally speaking. So I think it is quite well preventable.
Yep. So we look at hepatitis B and hepatitis C, right? And I know there's a time when there's a vaccination campaign that was actually rolled out, but there was a lot of objection with regard to the same because perhaps the government did not communicate well. Many did not know why that was being done. But just speak to us in terms of the prevalence, first of all, of hepatitis B and C, and what then early diagnosis of that and management early would translate to fewer liver complications.
The prevalence of hepatitis B and hepatitis C all over the world is reducing. In India, we don't see hepatitis C very frequently as we used to, say, 10 years ago, because most of them have been diagnosed, have been treated. Hepatitis B vaccination is very strong back home. So the incidence of hepatitis B has come down dramatically. So that is the effect of public health on the population. And that is where we see the rise in diabetes-related or NASH-related problems. Here, when we do a campaign, the first thing to do is to disseminate the knowledge of why we are doing it. If we are able to reach the grassroots population, at birth, the vaccination should be mandatory. There shouldn't be a choice in vaccinations of this kind, which are proven all over the world. You make it a choice, people always think, why should I do that? Right? So if it is mandatory, all kids at birth should be vaccinated. And while vaccinating or at the school levels, they can be communicated or they can be educated that this is what it does, this is what it prevents. Because once there is hepatitis B infection, the risk of turning into a chronic hepatitis B infection is in the range of 20%, which is very high. And in those 20%, you leave it over the next 40 years, very likely they will become cirrhotic. And you may be screening them, you may be constantly doing scans, but there is no way of stopping what is happening. It's a matter of time that slowly the liver gets damaged. And as of now, there is no curative treatment for a hepatitis B infection. So prevention becomes the main aspect. And the incidence of cirrhosis also increases in a hepatitis B patient. It can go as high as up to 40%. And the liver cancer, as I told you, in a cirrhotic patient, the liver cancer incidence increases dramatically. And that's what we are looking at. We should look at it deeply.
I mean, who is the best candidate? Maybe it's an obvious question or an obvious answer. Who is the perfect candidate for vaccination for hepatitis B? We know the fact that the government should have a stance on who is a candidate, who is a newborn, right?
Yeah.
But should everyone just walk in and get that vaccination, because then it protects you in the long run?
It is a possibility. In fact, whenever I see somebody, even if there's a lot of resistance to it. When we say you need to take a vaccine, they'll say, I'm fine, why do I need it? But I would always suggest that young people, if they have not been vaccinated or they don't know that they have been vaccinated, there is no harm in getting yourself checked first. If you're negative for hepatitis B, take the vaccine. There is no harm. If people are getting tattoos or they have gone through procedures, all of them should have been tested. If negative, get a vaccination. It is very simple, and it gives a lot of protection over time. So there's no age limit. Of course, somebody who is 60, 70, we vaccinate. The time, even if they develop hepatitis B, it would take 20, 30 years for the effects to come. So we don't insist at that age group. But a younger population, the youth, if they are not sure if they have been vaccinated, there is no harm if they take a vaccination. It's 3 doses, 0, 1 and 6 months apart, and you're protected. So that's something which we should look at it ourselves.
I want to let's look at liver disease, liver cancer, at a point where I've come to you and I need to, say, get a transplant. I just want us to be not as graphic, but to be as real as possible in terms of what it means for one to be told that they need a transplant. At what point does the doctor recommend that? 2, how easy is it for one to get a donor for the transplant? Number 3, what are the success rates?
Okay, fantastic questions. When we look at somebody who has come to us with a liver cancer, the first thing we look at is, can it be removed? Right. So if we can cut and remove it, if the liver is otherwise okay, then we don't immediately offer a transplant. We would rather remove that part of the liver, and as we know, the liver grows.
Yes.
So most patients they do well with liver resection, what we say. Now, unfortunately, many patients are cirrhotic already, where we have a limitation about how much we can remove. Or the cancer is in multiple places in the liver, and we have certain guidelines to help us decide who is a transplant candidate. But if they fit into the candidate, then fit into the criteria, then our first curative options, apart from resection, is liver transplant only. Anything short of a transplant is not considered curative, because we are leaving behind the diseased liver as it is, and there is always a risk of a new cancer coming in, even if we treat what is there with multiple procedures, different procedures. The risk is always there. So that's when we say, okay, this patient needs a transplant. Now, how easy or difficult it is to find a donor? Donation of liver is of 2 ways. One is a deceased donor and one is a living donor. Now, in India and in the East, we do a lot of living donors, where the relatives, a close family member with the same blood group, they say, okay, I want to give a part of my liver. So we take a part of the liver and we transplant it. We remove the liver from the patient and we put the donor liver, and that is a living donor transplant. Yes. And a deceased donor is somebody has met with an accident, they are brain dead. They're not going to get up, they're on ventilator. And we know that there are certain tests to prove that the patient will not survive because of this, and the family is ready to donate. They say, okay, I want to donate, we want to donate the liver, kidneys, other organs as well. So those are called as deceased donors. Now that is a matter of chance, right? How many can we generate? How many patients will actually donate? There is a huge gap between what is the donation and what are the number of recipients. Yes. And to bridge that gap, that is when living donor came in. In an ideal world, there would be no living donor transplant. It should all be deceased donors. But that is not the reality of it. So we have both these options to help patients. And it is, as of today, done at the right place with the right settings, the right candidate, considered a very, very safe procedures with success rates of 96%, which is a fantastic success rate for a surgery of that magnitude. And we see long-term outcomes. We see patients surviving 15 years if they maintain it well. We have seen patients going for retransplants. You know, that is the way where we have reached. But if it is not done at the right time, somebody is very sick, they don't get the treatment at the right time, then the problems, the outcomes can be bad. It can go as low as 65, 70%, which is still not bad considering that the outcome is that the patient is not going to survive. But still, when we look at it as a surgical outcome, we always want to be above 95%, right? So at the right time, it is a fantastic life-giving surgery.
Yeah. In closing, then, just speak to our audience today in terms of what they need to do not to end up at your operating table.
For a liver cancer, you mean?
Yes.
Yeah. Okay. It's very, very simple and basic. What our liver wants is a lot of antioxidants, vegetables, fruits, depending on whether you're diabetic or not, a lot of exercise. This is all the liver asks. Any patient who comes to me, the first thing I tell is, how much do you exercise? What do you eat? Consuming lot of fat-containing meat. Meat is good, but having a lot of vegetables with it, having a good amount of antioxidants, consuming good amount of water. This simple things, exercising 45 minutes, 1 hour a day, cardio with strength if you have the capability for it. This goes a long way, and the liver will thank you for it.
Yeah. Dr. Aditya Naragund is telling you what you eat determines whether you'll end up on his table. That exercise, as much as many say no to it, is important. And remember that when you talk about matters to do with liver disease or gastrointestinal diseases, it is all about your health-seeking behavior. Go to your medical practitioner, have you checked, and seek medical advice when you need it the most, not when it's late. Remember, this is Health and Wellness. I am Dennis Aseto, and here we keep telling you that your health is your wealth. Therefore, take care of it. Until next time, bye-bye for now.